Alright, lymphadenopathy. Lymph nodes have a pivotal role in determining the outcomes of the patient and has a very central role in determining that what treatment plan should be executed. Now, this short video presentation will basically focus on how to identify lymph nodes at different levels from level 1 to 5 of the neck, and for what level which appropriate slice should be used. So let's see how it goes.
Alright guys, let's start with the imaging of the lymph nodes. This short video lecture is basically based on a CT interpretation of lymph nodes. Now every resident, especially the junior ones, will always come up with one question, that show me where the lymph nodes are, show me where the lymph nodes are. Now, first of all, one thing you need to keep in mind, especially this question is the favorite most question for the maxillofacial and the ENT residents. One thing which you have to keep in mind is that you cannot appreciate lymph nodes until and unless you know the normal anatomy of the suprahyoid neck and the infrahyoid neck. Alright, for this you have to see and go through the presentation of the suprahyoid and the infrahyoid neck in the part 3 of the previous presentations. Now, first of all, starting with the classification of the lymph nodes, there are almost 800 lymph nodes that are present in the whole of the body, and above 350 plus and counting are present only in the neck region. So you can see how important this region is. Lymph nodes are basically embedded within the loose fat tissue that is surrounding the internal jugular vein present inside the carotid sheath, and in the areas like in the segmental region and in the level 2. Now, first of all, the classification of lymph nodes, as we all know, submandibular, segmental lymph nodes, they come classified as level 1. Level 2 is along the internal jugular chain and surrounding the internal jugular vein present inside the carotid sheath, and it level extend from the skull base to the hyoid bone. Level 3 is from the hyoid bone up to the cricoid cartilage, and the level 4 is the infraomohyoid around the internal jugular vein up to the supraclavicular fossa. Level 5 lymph nodes, these are present in the posterior triangle. Level 6 are the pretracheal nodes. These are basically related to the pathologies of the thyroid gland. And level 7, these are the supraclavicular nodes which we classify. Now, all of the lymph nodes of the head and neck are not included in these 7 classifications that are made. Now, there is another set called the facial, the mastoid, the occipital, and the retropharyngeal nodes. These are not included in this level, and this is also one of the shortcomings of this TMJ classification. The facial node is the blanket term for nodes of the mandibular, buccinator, infraorbital region, and retrozygomatic area, plus in the malar area. Here you can see these are the buccinator, these are the preauricular, and these are of the mastoid region, and these are the occipital nodes. These red ones are the conventional level 1 and 1B lymph nodes. These nodes, if they are identified, then you simply write their designation along with the area where these are found, and consequently the number and size of these lymph nodes. Occipital, facial, mastoid, again they are not included in this system. Now, this is the good diagram that shows all of the levels: 1A, segmental, 1B, 2A, 2B, 3 from the cricoid starting, and from the base of mandible up to the cricoid, and then below the cricoid level 4, and in the posterior triangle the 5A and 5B level. All of these are taken out in the functional neck dissection. Here is a typical presentation of the lymph nodes. If you compare the anatomy, draw an imaginary line over here and compare the anatomy on the both of the sides. This is a hard bone, this is the base of the mandible. Here you can see the submandibular nodes, enlarged nodes. You can't appreciate on the left side of here. This is the sternocleidomastoid mastoid that has been pushed by the enlarging size of these lymph nodes. Now it is, first of all, it is very important to differentiate between the levels, the level 5 and especially the level 2A and 2B level. These are the level 2 will be present medial, on the medial aspect of sternocleido, along the submandibular gland, behind the submandibular gland, and level 5 will be on the posterior medial aspect of the sternocleido. Okay, now here you can see, appreciate, starting from level 1A, these are the this is the submental level. These are the digastric bellies, anterior belly of digastrics. Here you can see a large, very large node again here, and again 1B level you can see along the submandibular gland, and level 2 nodes. This is basically bilateral diffused lymphadenopathy. You can see it in both sides, and along the pathway of the internal jugular vein. This is the sternocleidomastoid, and on the medial aspect of it is the level 2B. This is not the level 5. Level 5 would be present down and on the posterior medial aspect of the sternocleido. This is the internal jugular vein. Here you can see it is always and almost found near the internal jugular. Now one thing more, while describing the lymph node, while finding the lymph nodes, one should keep in mind that first of all, where to look for the lymph nodes. Now obviously this comes out to be a stupid question, that where to look for. Obviously it is from the level 1 to level 5 of the neck, but we should always start with by finding the internal jugular, the level 2 lymph nodes, and the level 1B lymph nodes. Now these are special sets. We will describe it later on, that why do we start with the level 1B and the level 2 lymph nodes. Basically the jugulo-digastric and the jugulo-omohyoid lymph nodes. But first of all, why do we find these lymph nodes? Here you can again see the sternocleido. This is the external jugular vein. This is the internal jugular vein. This is the carotid. This is at the level of the thyroid cartilage, level 3, which you can say. Here we see only the common carotid artery, because the common carotid bifurcates at the level of C4. Here you see the lymph nodes, level 3 nodes. These structures would normally not be present on on a normal CT. Lymph nodes are not visible on normal CT if they are enlarged, they are pathological, or even due to any infection. Reactionary nodes would be visible. On a normal CT you cannot appreciate lymph nodes, but this criteria is not necessarily effective. On the anterior border, here you find, this should not be confused with the lymph node. Lymph nodes do not appear very bright or very hyper intense, just like the vein, because of the contrast they have taken up. This is the external jugular vein. This is the interior jugular vein. This is the internal jugular vein. This is the common carotid, and here you find an accessory structure which is called the lymph node, the enlarged lymph node at level 3, and here as well as on level 2B, which is on the medial aspect of the sternocleidomastoid. Now jumping on to the next slide, here you see the level 5. See the relation of this to the sternocleido. This is on the posterior lateral aspect. See here, again posterior, very posterior to it. Here again level 5 nodes, and first of all see this level of the C6 vertebra. So to identify the level, the vertebra should be taken into account, and you should know how to identify these vertebrae. First, these. Now again, these are the level 5 nodes. This is the level 4. Now on a slide which will be present superior at the level of C3 or C2 level, this node would not be a level 4 node, this would be a level 2B node. I hope you understand this point. Now the most important things that you need to remember while diagnosing the nodes in a cancer patient is that the size, and the size does not necessarily means the size of every node. First of all, at the start I said that why to look in the jugulo-digastric region. Now the jugulo-digastric and the jugulo-omohyoid region, these are contains the largest nodes that are normally present in the neck region, with an average diameter of 1.1 to 1.3 centimeter, which can be very accurately calculated on the software of the CT. You cannot judge it over. You can judge it, but you cannot accurately judge it on the conventional slides that are provided to you. The jugulo-digastric node that is greater than 1.5 centimeter is a pathological node. However, if it is present between 1.1 to 1.3 centimeter, then it is called a reactive node. It may be pathological, it may be reactive. The second largest group is the jugulo-omohyoid that drains the tongue, and the normal size is 1 centimeter, considered to be normal in size. The same criteria applies to the other nodes. Now, any lymph node except the jugulo-digastric nodes, any node regardless of the size, if it is visible on a CT other than the jugulo-digastric node, it is always a pathological node. Now first of all, you need to keep in mind that we are talking only about the cancer patients. I will repeat it again, that any node in any other region except the jugulo-digastric chain, if it is visible on a CT, it is always a pathological node. Now coming to the criteria of enlargement, the size criteria of cervical nodes is supposed to be the short axis diameter greater than 11 millimeter in the jugulo-digastric region and 10 millimeter in all other cervical nodes. So jugulo-digastric is the largest nodes. Now second thing which you see, it is not only the size which you have to see, there are other features of the lymph nodes that have to be taken into account. One is the low attenuation. There are only few things which you need to know. First is the attenuation of the lymph node, the shade of gray that is given. The attenuation means the act of thinning or weakening if the radiation passes through that lymph node, and if the lymph node is enlarged, contains the necrotic element, the keratin pools, then it will show a low attenuation. Now if it is showing a low attenuation, it does not necessarily mean that there is any element of central necrosis in it. It can be keratin pooling, it can be necrosis, and it can be the lymphoid tissue as well. And it is one of the most reliable signs of metastasis in the head and neck region. Now there comes the cystic nodal metastasis. Cystic nodal, it appears like an abscess with the well circumscribed margins and clearly differentiating it from the other tissues as well as the inside tissue of the inside contents of the lymph node. However, cystic squamous cell carcinoma in the metastatic cervical lymph nodes is now considered to be a typical presentation of the SCC arising in the oro and the nasopharynx. It has been suggested that this phenomena is secondary to the pseudocystic change and result from spontaneous degradation of the keratin and the cellular matrix within the carcinomatous lymph node deposits. Now, the incidence of cystic nodal metastasis is range from studies from where it has been calculated from 37% to 62%, and quite a wide range, but cystic nodal metastasis is present. Now, if it is large, it is maybe misdiagnosed as a branchial cyst in children only. Now, why not in adults? Because adults almost and always have been treated for the branchial cyst. So branchial cyst should not be included in it is not included as a differential diagnosis in the adult patients. May represent as an occult metastasis of the squamous cell carcinoma. Here you can see on the right side there is a cystic node that is present between the internal jugular and the common carotid artery, which is pushing the internal jugular way beyond its limits. A large node with the cystic change, so see the attenuation level and see the well circumscribed rim and the hyperdense area surrounding it. This is a node not present on the other side. This is taken at the this is basically the this is basically the level 4 of the neck. Here you see the thyroid gland. Now, extracapsular spread, one of the most drastic factors that dramatically decrease the prognosis of the patient. If you see this, the patient is really, screwed up. The extracapsular spread is the infiltration of cancer cell beyond the capsule of the metastatic lymph node. The lymph node will not appear as round. It will not appear. Normally, the lymph node, if you see, it is ovaloid in shape. However, if it is pathological, it becomes round. And there is the fatty hilum will also disappear. It is irregular in case of extracapsular spread, fuzzy borders, fat strandings, and there are almost 10 times more chances of recurrence than node without having an extracapsular spread. And CT, it can be better differentiated as compared to an MRI. Now, as the size of the node increases, the percentage or the chances of having an extracapsular spread also increases. It is 74% in a node which is greater than 3 centimeter in size. However, in less than a centimeter node, there is only 23% chance that it will show extracapsular spread. Now, it is the best predictor of local treatment failure. Now, this is also this extracapsular spread is also one of the shortcomings of the TNM classification, because it is not included. It dramatically decreases the prognosis of the patient. Now, in case if the node is if it is surrounding the carotid or the vital structure, now the thing is up to which level or it is resectable or it is non-resectable. That will alter your treatment plan accordingly. If the circumferential encasement of the carotid is more than 270 degrees, then it is considered to be unresectable. If it is less than 180, then it is resectable. If it range between 180 to 270, then it is the choice and the expertise or the skills of the surgeon who can deal with it. Now, here is a typical example of extracapsular spread. You can see that the ragged borders, it is like appearing as a tumor instead of a node. Bilaterally, you can see the shape is not rounded. It is like a squarish rhomboid shape. On the other side as well, it is appearing as a tumor. You can see the margins here that are ragged margins, and absolutely distorting the nearby anatomy as well, and you cannot sometimes clearly differentiate between the infiltrated tissue and the node as well. This is the level 2B lymph node that has shown extracapsular spread greater than 3 centimeter in size. Now ultrasound is supportive but has developed a great significance. We can have another short presentation on how ultrasound can guide you for the identification of the metastatic nodes. Now clustering is another pattern of lymph nodes which you can see. Here you can appreciate nodes present in a botryoid fashion, a bunch of lymph nodes present. These are quite small lymph nodes, like 1, 2, 3, 4, 5 lymph nodes here present here, and this pattern is called the clustering pattern. Nodal calcification, you can easily confuse it with an exostosis of the bone or hemorrhagic vascular tumor. And first you must have a brief history of the patient as well before declaring it as a nodal calcification. It is seen in the lymphoma patient as scleroderma, sarcoidosis, silicosis, amyloidosis, and seen most commonly in the papillary thyroid carcinoma and in the tuberculosis. Bilateral diffused lymphadenopathy, here are some of the differentials. They can be reactive, most commonly seen in children, infectious nucleosis, in AIDS, lymphoma, sarcoidosis, histiocytosis, Kawasaki syndrome, Kesselman disease. Now if you see a vascular hilum within the node, or vessel is passing through the node, then then always think of this disease. However, squamous cell carcinoma in very advanced stages, it can present as bilateral diffuse lymphadenopathy, and in that case, or even in case where the nodes are bilateral in the neck, usually the patient is referred to the oncology department for the palliative management, because the treatment is not much successful even after radical neck dissections. Now, one of the most common mistakes in interpretation of the nodes is that the scalene muscles that appear asymmetrical can mimic a lymph node in the supraclavicular region or other neck locations. Poorly opacified and non-enhanced vessels can even confuse a lymph node with themselves. Localized hemorrhage, when it is focal, it can mimic a lymph node. Alright, here you see at the level of the digastric. Here you see at the level 1B, 1A, this is the 1B level, and clear nodes that are that can be identified as abnormal structures. Normally in a normal healthy individual, these are not present. Now this is again a clustering pattern of the lymph nodes which you see here. 1, 2, 3, 4 nodes are present. And this is at the level of C5 vertebra. Here you can see a chain of lymph nodes in the level 2B region. Here you can see the level 2B region, a chain of lymph nodes starting from the internal jugular and extending posteriorly across along the medial aspect of the sternocleido. On the contralateral side, normally, absolutely normal. one internal jugular, and these two are the carotid, internal external, at the level of the hyoid bone. Here you can see a chain of lymph nodes at the level 2B level. It is now essential to differentiate between the large lymph node vessels and the fat tissue of the neck. It is not possible on a CT slide, on a single slide of a CT. Now the simple rule is that for a vessel it would be visible on 2 or 3 or 4, even 4 slices, whereas a node will present only not more than 2 slices of the CT, 2 consecutive slices of the CT. It won't be visible. If it will be visible, it will be also in greater in the circumference, from where you can identify it clearly and differentiate it from a vessel. The diameter of the node will also increase if it is extending beyond 2 slices or 3 slices or 4 slices. Obviously it won't elongate in a single direction. The diameter will also increase. So for a node you have to check 2 things. The first is the cross-sectional diameter, and secondly, in how many slides superior inferiorly it is extending. A vessel will not extend beyond a lymph node will not extend beyond 2 slices. However, if it is enlarged, it can extend, but the cross-sectional diameter of that node in the medial and the lateral aspect will also increase. So that will help you in identifying that is it a vessel or is it a lymph node. Now coming on to the next slide, the lymph node with central necrosis is present. Here you can clearly differentiate it. These two are the vessels of the neck, normal vessels. Pretty much sometimes it's very hard to identify these, but the neck should be examined very carefully because it is not it is quite very often that you miss lymph nodes. Here again you can see these isolated masses of lymph nodes not present on the other side, present at the level 1B. These are the digastrics, lateral to it, anterior to the submandibular gland. Here again, bilateral lymphadenopathy, enlarged lymph nodes. Obviously, now this point I will clear it again. This cannot be a vessel. See the cross-sectional diameter, it won't be a vessel. However, it may extend for more than 2 slices, but the diameter that it is giving us, it is clear from it that it is a lymph node, it is not a vessel. Again, lymph nodes. Here again on the left side, lymph nodes, and these are the this is the internal jugular, and these are the great vessels of the neck. These two small are the vertebral arteries, and these are the longest capitis, and these are the inferior constrictor muscles of the pharynx. And you cannot differentiate by a clear line that. However, in an MRI, it can be they can be visible. Okay, an additional thing. Now, this is an enlarged node, diagnosed. Enlarged node. You can see the diameter greater than 6 centimeter, and why this area is hypodense is the reason is that the contrast is unable to take up. It is unable to take up the contrast in the central area. This is a large node, a huge node greater than 6 centimeter. Now the last thing which you need to know is that as I told you, vessels, the fat, and sometimes the scalene muscles of the neck can be confused with the nodes. Here is one thing more. The tail of the parotid. Now in this region, when you at the level 2B region or in the submandibular region, you should be able to identify the tail of parotid from the node. Now this tail of parotid will be present outside the sternocleidomastoid on the lateral aspect. However, most of the nodes are usually present on the anterior or the medial aspect of the sternocleidomastoid. Here you see the nodes, here you see the nodes, here is the node, here is the node, this is the node, this is the node, this is the internal jugular vein, this is the carotid, and you can clearly differentiate it based on I mean it is more hypodense as compared to the vessel. And here you see this gland, due to its water content in it, it is appearing even more hypodense. So here at this level you should be careful, and this thing should be kept in mind. The tail of parotid should be differentiated from the abnormal nodes. Alright, so thank you. If you like this video, please hit the like button and please subscribe to our channel. And if you have any additional knowledge to share, or please comment on the comment section below. And these are totally for educational purposes. If you think you have some more information to give, or you have something to add upon this, so kindly comment it. It would be highly appreciated. So thanks for watching. Allah Hafiz.
Please subscribe to our channel on YouTube, and if you like this video, then hit the like button. And if you have any knowledge to share on, or any comments regarding this video or relevant to this, so please share it on the comment section below. Thank you for watching.